research base for prolonged exposure in the treatment of PTSD, and then quickly go over the treatment structure and a session-by-session overview of what the treatment is. And then I'm going to focus most of the time on these key elements of prolonged exposure. A part of the psychoeducation component, which is presenting the rationale for treatment, in vivo exposure, and imaginal exposure. So when I talk about exposure, what I'm referring to is repeatedly approaching a feared but relatively safe stimulus in such a way that distress decreases over time. So whether you're doing an exposure-based treatment with someone who has spider phobia, or with obsessive-compulsive disorder focused on contamination, or with someone where the core of their fear is inside their own mind, like we see in PTSD, where the thing they're most afraid of is the memory of the trauma, the concept of exposure is the same. So in prolonged exposure, the primary kinds of exposure that we use are first in vivo exposure, which refers to anything external to the person, doing exposure to situations, places, and people that might remind you of the trauma. And there's a large imaginal exposure component, which in prolonged exposure involves exposure to the trauma memory itself. So here, to give you a sense of the overall structure of the treatment, typically the active treatment phase is about 9 to 15 sessions. And in prolonged exposure, we do 90-minute sessions. It's too much to fit into a typical 50-minute session. So before doing prolonged exposure, it's important to do a good assessment of PTSD symptoms. And this just gives you a sense of the structure over time. The focus of the first session is primarily on psychoeducation, although there are other components as well. In the second session, it's beginning in vivo exposure. In the third, the first imaginal exposure. And then you're working in the intermediate sessions on gradually increasing the intensity of the exposure practices over time. And then the final session focuses on relapse prevention. And there's often a follow-up phase that involves booster sessions just to help maintain and continue progress. So now moving quickly through a bit about the outcome research. Really, this is just to say there's a lot of good data on prolonged exposure. This is a treatment that's been around for a little while. And this is just giving you a snapshot of some of the data that's out there to support the treatment. So Powers and colleagues came out with a meta-analysis in 2010 that reviewed 13 studies. There are more studies than that out there of prolonged exposure, but those are the 13 studies that met their inclusion and exclusion criteria. And they found a moderate to large effect size for PTSD symptoms and secondary outcomes as well, things like depression compared to control conditions. And really notably, the average patient in PE fared better than 86% of patients in control conditions across these studies. In 2007, the Institute of Medicine came out with a report concluding that exposure therapy is the best supported treatment out there for PTSD. And in the VA and Department of Defense practice guideline for the management of PTSD, exposure-based therapy is pointed to as a first-line treatment. So now I'm going to briefly go through what the contents are session by session and then delve into some of the most important components. And this is all based on these books by Edna Foe and colleagues that are great resources to pick up if you're interested in learning more about PE. There's the therapist guide on the left here and then the client workbook. So just to remind you of that overall treatment structure. So in the assessment phase, really what you're looking for here is to make sure that the first person meets criteria for PTSD and that that's the primary diagnosis, that it makes sense to be working on PTSD at this time. So if someone, for example, has unmanaged or unmedicated bipolar disorder, it's probably not the time to be jumping into work on PTSD, but at some point later in their treatment, when their bipolar symptoms are better managed, their mood is stable, that might be a great time to work on PTSD. And just to quickly note, there have been some changes recently in the PTSD diagnosis as we're moving from the DSM-4 to the DSM-5. And that's not something that I included in the talk today, but if you have questions about it, feel free to ask me. They're fairly interesting and kind of substantive changes that have been made in the diagnosis. When I'm doing assessment with someone with PTSD and trying to evaluate whether it's a good time to do prolonged exposure, I just have additional caution when I'm talking with someone who describes suicidality or substance misuse. These aren't rule-outs for the treatment. but places where you just want to tread a little more cautiously and do some really good assessment. So if someone has some suicidal ideation, that's common in PTSD. It's not something that would necessarily throw up red flags, but I'm going to be much more cautious if recurrent self-harm, et cetera, or in the presence of a plan or intent. Again, this is just trying to determine whether this is a good time to be doing PTSD treatment. And with substance misuse, really, you're just trying to ensure that the person can actually benefit from the treatment. So if a substance problem is present, but you get a sense that it's secondary to the PTSD and the person could work on reducing substances to get through the treatment, that still may be a time when you could do PE. And there's some interesting research supporting that usage coming out these days. In the first session, the focus is really on introducing the person to the treatment. So we talk about the structure of prolonged exposure and spend a lot of time on psychoeducation and a rationale for the treatment. We really want clients to understand why we're asking them to do some kind of difficult things in this treatment, so the rationale is really important, and you'll see it crop up a bunch of different times. It's also part of the Session 1 protocol to do a standardized trauma interview. You can find a version of this in the treatment manuals that I showed up on the screen a bit ago. And there's also a version focused on recent veterans from the wars in Iraq and Afghanistan that Edna Foe and colleagues published. So this is just a chance to get some more information about the primary trauma that you're going to be focusing on in the treatment that will really help you a little bit down the road when you start heading towards the imaginal exposure. And then in the first session, we instruct people in paced breathing and what we call breathing retraining. So I'm sure a lot of you are familiar with describing to clients ways to change their breathing to calm anxiety, and this is just a version of that. So we do breathing retraining in this treatment for a couple of reasons. I'm really glad we have it in the first session because it does give clients something that they're actively working on after that very first session to help themselves and progress with their anxiety. And it comes in really handy as you're asking the person to do exposures. It's a go-to distress tolerance strategy that they can use. What you want in exposures is the person to persist and continue to approach the thing that they're doing exposure to rather than avoiding it. So having them do some breathing to be able to stay in the situation can really help. And then after the first session, the homework is to review a written version of the rationale, practice the breathing retraining, and listen to the session recording. All prolonged exposure sessions are recorded, and we send those recordings home with the client after each session. And this is just a chance for them to get the information in another way. Since during treatment, clients are often pretty anxious, it's really useful to have them be able to listen to the recording again at home. In the second session, we start with reviewing homework, and then there's a psychoeducation component focused on common reactions that people experience after traumatic events. In some versions of the protocol, people present a video in the second session. I did that when I was in a research trial doing this treatment, but it's not something that I do now in private practice because I don't have access to video that would be useful that way. And I know it's something that they do in the VA as well when clients are doing prolonged exposure. Next, in session 2, we present a version of the rationale focused on in vivo exposure and explain how we rate anxiety, which is called the SUDS scale, and I'll come back to that. And then work together to develop an in vivo hierarchy. And their homework is to do some initial in vivo assignments, read the common reactions handout, so another way of getting that information in, reviewing and expanding the hierarchy you developed together, continuing the breathing retraining, and listening to the session recording. Session 2 can also be divided up into 2 sessions. This is how it's presented in the VA rollout for prolonged exposure, where you do most of the psychoeducation in kind of a session 2A and then the in vivo part in session 2B. When I'm doing this in practice, I just get as far as I can in the session 2A, and then if needed, I'll continue to really focus in vivo exposure in another session. In session 3, the primary focus is presenting the rationale for imaginal exposure and providing instructions for doing the first imaginal exposure and then doing it. So as you can see, of course, you always start with homework review. We do the rationale again, another version this time focused on imaginal exposure. I'll come back to these metaphors. And then it's all about just getting through that first imaginal. And following the imaginal exposure, there's a period for processing. And I'll talk a little bit more about what that means as I delve into that piece. And then the homework is to listen to the Imaginal recordings daily, listen to the session recording once, do in vivo assignments, and continue breathing retraining. As you progress in the intermediate sessions, the focus is on increasing the intensity of exposures over time. So starting to progress to hotspots and imaginal exposure, which are the most difficult parts of the memory. So every session, you kind of get into a routine at this point. Every session starts with homework review, and then you focus on imaginal exposure during the session. And then as homework, they're progressing with imaginal exposure and in vivo exposure. And then in the final session, they do imaginal exposure to the full memory rather than the most difficult pieces, which you've worked up to in those intermediate sessions. Continue with the processing, and then the focus is on reviewing progress and doing relapse prevention. And setting goals for continuing to work on their remaining targets. So now to delve in a little bit more on these crucial components of the treatment. I'm going to start by describing a bit more about the treatment rationale and how I present that to clients. So when presenting the rationale for prolonged exposure, we really talk about PTSD as a set of reactions that immediately after trauma are really expected and a part of our natural response to really extreme and traumatic events. So what I tell clients is that immediately after a traumatic event, pretty much everyone has the symptoms that we later describe as PTSD, things like intrusive memories coming up when they don't want to think about it, avoiding things because of the trauma, having hypervigilance or hyperarousal in different situations. And for some people, these symptoms naturally decrease over time, but for other people, the symptoms stay high. And that's what we later call PTSD, it's symptoms staying high over time. So then really the kind of $50 million question becomes, what is it that maintains post-traumatic symptoms? Because those are the things that we might want to target in treatment. And there are two primary factors that we've identified through the research that really seem to contribute to maintaining post-traumatic reactions. The first is avoidance. And avoidance can take many forms. When people have been through a traumatic event, they tend to avoid thinking about that event, the memory of it, their emotions related to it, and things in the environment that might remind them of it. And when I talk about avoidance with clients, I always start by saying that avoidance makes total sense. Of course, if something is really distressing to you, it brings up a lot of painful emotions, you're going to want to avoid that. It just makes sense. Unfortunately, it works in the short run. It does bring down anxiety right then, but in the long run, it seems to really maintain post-traumatic reactions. So it's something we target in treatment. And then the other piece that seems to prolong post-traumatic reactions is the presence of extreme and unhelpful beliefs as a result of the trauma. So things like that the world is a dangerous place, people are untrustworthy, that someone's symptoms mean that they're incompetent or can't cope with things, that the trauma was their fault, those kinds of beliefs. So avoidance and these extreme beliefs are things that we target in prolonged exposure therapy. So what I'm going to show you here on the left, this is how I think about avoidance, and I describe verbally to clients. And on the right, I actually draw this figure for people up on a whiteboard or on a piece of paper. So when someone comes into treatment with PTSD, they're kind of stuck in an avoidance loop. So fear cue arises, starting over here. Their anxiety goes up in response to it, and at high levels of anxiety, we all wind up wanting to avoid. We get in that fight-flight mode. And so the person engages in some avoidance behavior, leaves the situation, decides not to go at all. And anxiety decreases. So the curve looks something like this. If we've got fear and anxiety by time, they approach the situation, anxiety goes up, they get to some point of intense distress, and the desire to avoid, they engage in some avoidance behavior, and anxiety goes down. It's a really reinforcing pattern. It makes sense that a person would do it. But they get stuck in this loop that every time they approach that same cue, every time they encounter it, they have anxiety go up, they avoid, and it goes down. But they never get what they really want, which is long-term resolution of anxiety. And what I tell clients is that it's like this gives your brain a really particular kind of message. And that message is, this situation really was dangerous. I got out just in time. Something awful could have happened. I can't tolerate anxiety, those kinds of ideas. So you get short-term anxiety reduction, but long-term anxiety maintenance. The new learning that we're looking to promote in prolonged exposure is a little bit different from that. Rather than avoiding, we have people approach feared cues, and we block avoidance behavior. We actually have them stick in the situation despite high urges to avoid. And what happens is that it's like the emotion is able to take its natural course. Yes, distress comes up, but at some point it will come down on its own. We just can't maintain a state of high arousal indefinitely. And this gives your brain a really different kind of message. So we're talking about approach of both internal cues like the memory and external cues, situations, etc. But the message that this pattern, blocking avoidance and allowing the natural course of emotion to occur, gives to your brain is something more like, this may not be as dangerous as it feels. I can tolerate this situation without having to avoid it. I don't have to avoid to get relief. And with multiple repetitions, those messages sort of become a little bit more ingrained and the person's fear goes down. So they actually get long-term anxiety reduction. So the curve looks something like this. You'll notice that at the beginning, as you approach something that you've usually avoided, yeah, anxiety is going to go up past where it would have if you had just avoided the situation altogether. That's to be expected. But at some point, distress goes down on its own. And with multiple repetitions, the situation gets easier and easier and distress goes down. So what we're asking the person to do is gradually approach trauma-related situations and the trauma memory so that a few really important things happen. They get a chance to process the traumatic event in a way that you can't when you're caught in avoidance, when you're pushing away the memory at every turn. It's sort of like our brains need a chance to actually try to make sense of and think about and understand what happened. And that processing can take place when you're doing exposure. It helps to differentiate the memory from the trauma and highlight that memories are not dangerous the way the traumatic event was dangerous. People experience trauma memories when they have PTSD almost like the event is happening again. The level of intensity is so high. So there's this process of kind of differentiating the trauma itself from the memory of the trauma. And we're promoting new learning. So I have up here this idea of habituation, which is that graph of anxiety decreasing with repeated exposure. But the term habituation has a particular meaning, and we're coming to understand through research on prolonged exposure that habituation isn't actually the best term for it. It's actually kind of extinction. I'm not going to go into nitty-gritty details of that. But the idea is the learning that takes place when, because you repeatedly approach something without avoidance, your anxiety comes down. And then learning that also helps change extreme trauma-related beliefs about oneself, other people, and the world. So as a result of doing exposure as well, life becomes less restricted. People feel better able to do the things they want to do in life. And they develop a sense of mastery and competence, a sense that they can handle situations that they were feeling like they really couldn't. So when I talk with clients about this, I also typically give a brief description of what I mean by extinction. I don't always use that word, but sometimes I do. So what I'll tell people is that it's sort of like during a traumatic event, your brain attaches the feeling of fear and distress that you had at the time to basically anything in the environment that could be an important cue for danger in the future. So your brain is trying to keep you safe by making all of these associations. But unfortunately, it's not terribly selective. So those feelings of fear get attached to things that really are dangerous, but also things that are unlikely to be dangerous, but that just happen to be present at the time of the trauma. So for example, yes, someone will feel distress if they were assaulted by a bald man with a gun. At seeing a gun, we would expect that that is a danger cue. But they would also feel potentially anxious at seeing someone who was a bald man, even though that in and of itself doesn't necessarily indicate danger. So what we're trying to do is take that association between these triggers and their fear, which I typically describe as like a well-worn path in the brain, a really strong association, and create new learning that can kind of counteract the power of those connections. But creating new associations with these events doesn't mean that the old path disappears. It doesn't mean that that original learning from the time of the trauma disappears altogether. It means that it gets changed and kind of contextualized, and both responses become available to the person. There's a possibility that they could have a safety response and a possibility of having a fear response. And what will determine whether they have that safety response or the fear response is the presence of other cues in the environment that help their brain determine which way it needs to go and help kind of disambiguate the situation. So what that means is that we need to practice exposure in lots of relevant contexts. in lots of different kinds of environments where the person is feeling a sense of danger, but that are objectively safe. So continued exposure helps the brain proceed down kind of the most appropriate path. So now I want to talk in a little more detail about this idea of in vivo exposure, which is a process of reclaiming activities that have been limited or restricted because of the trauma. To start with, we really repeat the rationale a number of different times over this treatment. I won't do that now, but it is something that we repeat again in going into in vivo exposure, just to remind the person why we would ask them to approach these challenging situations. And I typically give people an example at this point. The one that I use most commonly is this first one here, the boy on a beach. So just to give clients a sense of what I mean by exposure, and that they kind of have a natural idea in mind of what exposure is too. So I'll say, let's say you were walking down the beach with a small child and having a lovely day, and then at some point the child is close to the water and gets kind of walloped over the head with a big wave and just becomes terrified, screaming, crying the whole bit. And then you notice the next time you go near water that the child is really, really afraid. You don't want this child to forever in their life be terrified of the water, so what would you do? And most clients have a natural idea of exposure that they describe. Well, I might start by getting them comfortable with like taking a bath or being in the kiddie pool or something like that, and have this idea of slowly and gradually getting closer to the thing that the child fears, being at the ocean. But if you do that and allow the person to get comfortable kind of at every step, the child will get more comfortable and no longer have that fear of water. I also like this metaphor because you wouldn't take the kid and throw him in the deep end of the pool, and we don't want to do that in treatment either. We start small and gradually work our way up and try to help the person get comfortable at a number of different steps along the way. And when describing this metaphor, I tend to say, PTSD or prolonged exposure therapy is based on the same kind of general concept of repeated exposure. But with what we see in PTSD, it's just much more complicated. The feelings of fear are attached to lots of different things. And so our job is to figure out how to best address the different areas of fear through exposure. So the next step is to have a way to be able to talk with your client about the level of distress that they experience in different situations so that you can create a gradual exposure process for them. So what we use is just a simple 0 to 100 scale. It's a subjective scale where 0 is being absolutely calm, no anxiety at all, but awake, not when you're asleep. And 100 is the worst anxiety or fear that you've ever experienced. So for some clients, this is how they felt at the time of the trauma, but certainly not for everyone. And before we start the hierarchy, we'll have people set anchor points to kind of calibrate the scale. These are things that you would not expect to change as a result of exposure, and that you can use along the way to kind of go back to, okay, this is what you said is a typical 50. Does this situation seem similar to that? It's just a way of knowing that you understand what the scale means and that doesn't change over time. So at a minimum, we get anchor points for 0, 50, and 100, but may get a couple more if needed or time permitting. So when you start to construct the in vivo exposure hierarchy, what you're looking for is situations that are objectively relatively safe, but are anxiety-provoking and have been avoided since the traumatic event. So the most important areas to focus are places where the person is just seeing a lot of impairment. They can't do the things that they want to do, and when where they're having to endure a lot of distress or discomfort. And here you look for guidance with situations that the person values or must encounter. So we don't just do exposure for exposure's sake. We want the person to be able to do the things that they either want to be able to do because they care about them, or they have to be able to do to get through their day-to-day life. So they may not love going to the grocery store, but we kind of all need to be able to do it. So we're shooting for a list of about 15 to 25 items. As I go through developing the hierarchy, I'm thinking about key themes and domains for that particular client. So things like crowded places, lines, driving, confined spaces. What you're really developing here, rather than one overall hierarchy, is a bunch of sub-hierarchies focused around particular themes that are important for the person to get more comfortable with. And you're also starting to look, as you create the hierarchy, for situational factors that seem to impact the person's anxiety. For example, whether they're alone versus with other people, the time of day that they do these things. For a lot of people, going to the grocery store, for example, is easier if they're with their partner, and if they go in the middle of the night when no one else is there. for other people, they would never want to leave the house at night, and they're most comfortable when there are lots and lots of people around. And you're also looking to start identifying safety behaviors. These are ways that a person can avoid their anxiety in a situation while remaining in it. So they're objects or behaviors that serve to reduce anxiety and function as subtle forms of avoidance. Like some people look at the clock repeatedly, keep their back to the door. That's a really common one that we talk about with veterans. Someone keeping their phone in their hand at all times, so if there was an emergency, they could call someone. Keeping their Xanax bottle nearby, that's certainly one that we see. And I want to go through a quick example here. This is a client that I saw who was, when I was at the VA, he was deployed to a peacekeeping mission, and a buddy was killed in the event that we focused on in prolonged exposure. So the first step was to generate this list, the hierarchy, get ratings, and for me to start kind of noticing themes in his exposure hierarchy. So this is what the hierarchy looked like. So you can see a number of different things on here and different levels of these items, so grocery store with partner, without partner, etc. And some of the themes that I picked up on are crowded places, enclosed areas, just the feeling of heat. This is a person who had been deployed to the Middle East, so heat was a cue, and socializing even outside of crowded or enclosed situations. So the next step is to select the initial exposures for the client to complete after session 2. Your goal when selecting initial exposures is to promote a success experience for the client, really for them to be able to do it with repetition as an exposure exercise and not wind up leaving the situation because of avoidance. So I pick things with relatively low SUDS. I really shoot pretty low with this. Some people shoot a little higher, closer to 50, but if there are things that a person says they have some anxiety about that are more in the 30 to 40 range, I'll start there. And I always select these collaboratively with the client where they think it makes sense to start, while also tempering that by making sure we're starting small and working our way up. And if possible, it's useful to start with things that the client is already doing with some amount of success, not things that are just total unknowns or that they haven't done in a really long time. In assigning the homework of in vivo practice, you have them record every time they practice their in vivo exposure, just the time and date, and then 3 ratings for their SUDS, their anxiety level beforehand, the peak over the course of the time they did the exposure, and then afterwards. And the general instruction is to stay in the situation until either anxiety goes down by about 50% of the peak, or at least 35 or 40 minutes if anxiety hasn't come down in that time. And what you're trying to promote is repetition and to stay in the situation for a prolonged amount of time. So it's not that you would send someone home to just go to the grocery store once. You're going to ask them to do it a number of times over the course of the week to get that repetition. So the next step is giving a copy to the patient to take home and refine. And then between sessions, I'll arrange the list in order of SUDS as a guide for me and the patient. In assigning homework, it's useful to forecast the process that they're likely to experience the first time they do the in vivo homework. That we can anticipate that they will have anxiety. These are things that are anxiety provoking to do. It's likely that they'll experience a desire to avoid doing the homework, avoid the situation, but that with repetition it will get easier. And I always highlight that this is really a therapy where you get out of it what you put into it. So the more time and effort you put into the practice, the more quickly situations can get easier. So as a therapist, you're always in this interesting position of reinforcing all progress and needing to kind of push gently over time to help the person do more and do things that are more and more difficult. When you're reviewing in vivo homework, the first time you certainly want to have the patient walk you through what they did for practice. You won't do that as much over later sessions because there won't be enough time, but it's something to definitely spend time on it at the beginning. You reinforce approaching and staying in the situation despite anxiety. You're taking note of safety behaviors that pop up and really highlighting any anxiety reduction that you start to see. So if a person started off doing an exposure and they were peaking at 60 and now they're peaking at 45, that's a huge amount of progress, and you always want to highlight that when you see it. This is a hard thing to do. So one of your primary roles is to be a cheerleader for your patients and really reinforce their progress and keep them feeling ready to go forward. And that you're making decisions collaboratively. So I mentioned before, you're kind of in this position of gentle pushing where the patient is in control, but you're encouraging movement. As you're climbing the hierarchy over the following sessions, you're working towards daily practice. You want to have them doing some kind of exposure exercise, some in vivo, pretty much each day. Ideally, you'll reach the top of the hierarchy a few sessions before you're done with the treatment and get a chance to over-practice some of the most difficult items. So they have multiple repetitions before they're done. And any particular item on the hierarchy is something you can let go of and kind of put to the back burner when their overall anxiety engaging in the assignment is low. Their peak is pretty minimal compared to the pre and the post. And they've repeated the items with low SUDS multiple times. Now, as clients move past particular in vivo exercises and go on to do new ones, it's not that they stop doing the first ones at all. It's actually really important that the person continue to do the behavior. They just don't need to do it as repeatedly or specifically as exposure in quite the same way. So next I'm going to focus in on the imaginal exposure component of the treatment. So this is the process of approaching the memory. In session 3, the primary focus is on starting imaginal exposure. And so you try to move really quickly to actually doing that component of the session, both because it takes a lot of time. So you're allowing about 60 minutes of the 90-minute session to be spent on the imaginal exposure itself. And also because clients typically have anticipatory anxiety heading into the imaginal exposure, so you just kind of want to peel the Band-Aid off. Again, you return to the rationale. It's sort of the thing that you do in the face of almost any problem or when introducing any new element of this treatment is to repeat the rationale. It's very, very helpful. Again, we use the metaphors to sort of describe why do this process of imaginal exposure, what we mean by this. So I typically use the filing cabinet or this infected wound idea. The filing cabinet one is described in Edna Phillips' therapist manual, and I think the wound one is as well, but I'll describe that one quickly. So I tell clients that it's sort of like the trauma memory hasn't healed properly. It's a place where they were hurt, they suffered an injury, and it just didn't heal right. And so it's like this part of them that's kind of infected. It may have healed over, they may be able to kind of get through life, but it's still really, really tender, and anytime it kind of bumps into anything, it's highly, highly painful. And so in order to get relief, and you actually have to kind of reopen the wound, unfortunately, which can be painful. You kind of have to open it and clean it out from the inside and allow it to heal properly. And that's kind of what doing imaginal exposure is like. It didn't work to avoid thinking about the memory. So the person can't kind of cover over it anymore. Instead, you need to open it up and actually look at the memory, approach it instead of avoiding it so that it can heal properly. And what happens is repeatedly approaching the memory decreases its power, it decreases that level of intensity, and we again return to this idea that avoidance, yes, it works in the short run, it makes sense that they try not to think about it, but in the long run, it tends to make anxiety worse. The next step, so you will zoom in on one particular trauma memory to focus on for the imaginal exposure, just one event, one day. And as you head into the imaginal portion, you want to pick the start and stop point for the memory. So a set time when the trauma kind of began, where it makes sense to start talking about it and where it makes sense to stop. And then you describe your role to the client. So during the imaginal exposure, you're relatively quiet, especially during this first one. You ask for ratings of anxiety every 5 minutes, but don't say a whole lot else. And the purpose of that is to really allow the client to be in control of the intensity of that first imaginal experience. They're kind of tempering or modulating how much they're talking about different elements, and to help them stay engaged with the memory itself. And the goal really is just to stick with it, to stay on the memory for 45 to 60 minutes. As you set the stage for the imaginal exposure portion, you first describe the procedure. So the client is asked to imagine the traumatic event as vividly as possible with their eyes closed, and to describe the event aloud in the present tense as if it's happening right now. This isn't how you would usually talk about an event. It's not the usual way we convey stories. So it's really helpful to help clients understand how we're asking them to talk about the memory. Instead, it's a slow motion version. And I usually say there's really no detail too small. So we want to walk through it moment by moment, including sensory components, emotions, thoughts, and sensations that they felt at the time, and really staying with that event. It's likely in the first Imaginal and in subsequent ones that they'll repeat the memory multiple times. They won't just go through it once, and that's, you're going for a set amount of time, that 45 to 60 minutes, not for just one repetition. As you start the Imaginal exposure, you switch to recording the Imaginal exposure on a different recording. They're going to listen to that at home as their Imaginal exposure homework, so it needs to be kind of separate from the rest of the session. You get a rating of their SUDS at baseline and prompt them with their chosen start point, and the client starts just talking through what happened in the event. In subsequent Imaginals, you'll spend about 30 to 45 minutes. That first one is just a bit longer. After the Imaginal exposure, you spend some time with the client processing what they experienced, what the process of Imaginal exposure was like. You're helping them to kind of reduce the distress they might have been feeling while talking through the memory. So it's a transition, a way of helping them kind of get ready to go back out into the rest of their life. And it's a time for you to reinforce their approach and engagement with the memory to, again, go back to that cheerleading role as a therapist. And you ask the client to reflect on the Imaginal exposure. So what was that like for you? What stuck out for you? As sessions go forward, you note the occurrence of anxiety reduction, both within a particular Imaginal, that their peak on one repetition might, and later in the session, might be lower than a peak at the first repetition. And also between sessions. After doing the Imaginal in session multiple times and doing the homework, peaks typically get lower and their overall anxiety goes down in talking through the memory. And as the therapist, you're also kind of noting things that you see as key elements and themes in the memory with this question in mind of what new learning is needed for this client. What do they need to sort of experience or understand with this memory that will help them correct some maladaptive beliefs or get more comfortable thinking about the event. So the functions of the processing are really to promote new learning, make a transition from the Imaginal exposure, reinforce progress, and promote engagement with the memory. As you look forward and help the person progress with the Imaginal exposure, again, the homework is a critical part. You're shooting for daily listening of the recording of the Imaginal exposure portion of the session. Realistically, clients are more in the range of, 4 times. I think that's pretty good if they're listening 4 times over the course of the week. But the closer you get to daily, the more quickly the client will experience anxiety reduction. And as you're moving through sessions and continuing through the Imaginal exposure, you're engaging in this process of increasing approach of the memory over time by having them increase detail. So you start being a little more active during Imaginals. You might ask questions to get a little more detail in key areas, especially detail around how they were feeling or sensations that they had at the time of the trauma. And you'll see decreased distress over time with repeated exposure, although it takes a little while. As you're progressing and getting closer to the memory, you're also progressing towards hotspots. These are the most distressing moments of the event. You identify a hotspot by looking for the places where they have the highest SUDS during the exposure, or places where they're experiencing the most re-experiencing symptoms, so intrusive memories, nightmares, etc., or the things that they most avoid talking about or thinking about related to the trauma. To progress to hotspots, I typically first kind of truncate the memory, so if there's a lot of lead up to the most difficult parts or a lot of discussion of what happened afterwards, I'll start to cut out those pieces and have the person start and stop in slightly different places. And then a few sessions in, progress to just focusing on those most difficult portions of the memory. These are brief moments that you're having the person describe really just in very, very slow motion, just almost excruciating level of detail, moment to moment, what was happening. And then rather than doing the full memory, when you get to hotspots, you're repeating the hotspots only for the duration of that Imaginal exposure part of the session. So you're going to repeat those portions of the memory over and over again in the course of one session. And in the final session, we typically have the client return to the full memory and the imaginal exposure. It's just a nice way of rounding out the treatment and getting a sense of how far they've come from that first imaginal. And then finally, I just wanted to say a little bit about becoming proficient with this treatment. I'm so delighted at your interest in the topic, and sadly, 1 hour is not enough to be proficient at this treatment. So I'd highly recommend, if you're interested in this, to get some additional training and consultation, to pick up those manuals. They're great resources. There are often workshops put on by Edna Foa's group at Penn, and other organizations, professional organizations, often have workshops available. You can also get individual consultation and supervision. If you find someone who will do this kind of consultation or supervision with you, I would definitely recommend having that be with recorded sessions that that person will listen to. It's much easier to learn when someone's actually listening to the content of your sessions. And this is something that I have some experience with, so if anyone is interested, feel free to contact me. And what I recommend is doing at least 3 supervised cases before you just embark out on your own in doing prolonged exposure. So thank you so much for your time, and I'd love to answer any questions.
Yeah. Thank you, Dr. Moore. It was really, really informative. So thank you for your time. So if anyone has any questions, you can send them over to the live Twitter feed at #PTSD webinar, or there's a text box if you want to type them in there. Before we get to that, just a little bit more information to give you guys. So just want to kind of give you some information about Valant. So Valant is a completely web-based EHR and EMR and a program management service. And so if you guys, they are who are providing the background information today and hosting this free learning series. So if you guys, if clients would like more information on Valant, they can reach out to us. I will just put up a quick poll here. And if you guys could just answer if you're at a place to get more information and would like someone to reach out to you, just respond yes to the poll on the screen. And if you are in a place where that's not appropriate for you right now, go ahead and answer no. Leave this up for a few more seconds. All right, just get a couple more votes in there. All righty, and then we'll get over to the questions. So if anyone has any questions, just send those over to the either the Twitter feed or the little text box on the right. Alrighty, and we'll get to questions here. There's a couple questions about getting slides for the presentation, things like that. We will get all of that answered later. We will not be putting the slides up, but we will have the recording of the live webinar up.
So let me address this question of anchor points. This is a common area of confusion, but not something I wanted to go into a ton of detail about. But it is kind of tough. So yeah, you're looking for things that you wouldn't expect to change. So these are either things that just are typically anxiety-provoking experiences, like someone might say as a time when they're at a 50 going on a first date, and a time when they were at 100. Well, the other way to go about this is things that happened in the past. Those aren't going to change. So when someone says, well, a useful 100 anchor point is how I felt at the time of the trauma, that is a good one to use. That's not going to change. How they felt then is not going to change. So it's a useful anchor. And then some common zeros are things like, after a hot bath, or when I'm on vacation and laying on the beach, or times when the person just has felt completely at ease. For some people, they haven't felt that way since the traumatic event occurred. So it's okay to say, how I felt after a hot bath before the trauma as an anchor point.
Okay. A couple other questions here. So there was a question about how dissociation is handled. So if a client is able to tell a story over and over but is really dissociated or not in touch with the emotion, how to handle that?
Yeah, this is a great question. So oftentimes clients have developed a kind of police report version. They can tell the story in a disconnected or detached way. This is, it's common that your work as a therapist will be on trying to increase the person's engagement with the memory, trying to help them actually feel a little bit more. So part of that is really increasing the amount of detail that they describe, helping them put themselves back there and describe all those sensory components, how they were feeling at the time, what they were thinking. And for a lot of clients, that will allow a greater level of engagement. I also will just, again, we talk about the rationale so much, and this is another place where if a client is having a lot of trouble connecting, I will go back to and reiterate the rationale, why I'm asking them to do something so difficult, why I'm asking them to stay in touch with the memory, engage with it, even though it's painful. Because sometimes it's just avoidance getting in there and that strong urge to not think about the memory.
All right, we'll get a couple more questions here. Looks like there's a couple questions about teenagers and children, if there's anything.
Yeah, so since I am an adult psychologist primarily, I'm not as familiar with the research on children and adolescents. I know there is good evidence for trauma-focused cognitive behavioral therapy, which is more of a child-focused approach, and there's an exposure component to that. So there is established effectiveness of doing exposure with kids and PTSD. It's just a slightly different protocol.
Okay. And for anyone we don't get to your questions today, we'll have Dr. Moore email responses. So we'll try and get to as much as possible. Looks like there's another question here about clients who are currently experiencing ongoing trauma. So would PE be appropriate for them? So like partner violence or things like that.
So yeah, this is a time when PE would not be appropriate. You're focusing on post-traumatic stress symptoms. So in order for this to be beneficial, they need to be post-trauma. If the person is still going through a recurrent traumatic event, then it's best to wait until a time when they really are post-trauma to do any PTSD work. At the time of when you're going through trauma, you need to have those fear responses. They're to be expected and really normative and a part of trying to help you get out of danger. So you wouldn't expect the stress to go down doing exposure while the person is in the midst of something traumatic.
Okay. And it looks like there is a question here, a couple more. We'll try and get to one or two. There was one about if this treatment is successful with long-term trauma or only a single incident trauma.
Another fabulous question. These are such great questions. Oftentimes people are confused when they think about PE because it is something where you focus in on a single event. But I would say really most of the clients that we see have been through more than one traumatic event in their lives, and we still do PE. So it's not something where they have to have only had one single experience. When a person has been through something recurrent where they experience kind of the same sort of event multiple times, for example, someone who's been through repeated childhood sexual abuse or a veteran who is deployed for a period of time to a war zone, what you do is you focus in on the worst event. You pick a target trauma and focus on that for the duration of PE. What we find is that if you pick a most difficult event or one that is one of the most difficult, progress generalizes down to other events because they share similar themes and similar fears, but it doesn't tend to generalize up. So if you start with something lower level and try to go from there, it doesn't tend to be as successful. Occasionally, when someone has been through more than one event, if they're really thematically different, you might have to do the imaginal component with two different events. Sometimes we need to do that in treatment. So you might start with one particular trauma and then later in the treatment go on to another. You're still trying to start with the worst so that the person gets as much progress as they can. And then you can kind of determine whether it's even necessary to go on to another event.
Okay, great. Thank you. And one more question. It looks like there is a question about the similarities in this treatment to other treatments for PTSD. So the question was, would you speak to the similarities or differences of PE and CPT?
Yeah, so CPT is cognitive processing therapy. It's another really well-supported treatment option for PTSD. In some ways, they're quite similar because the rationale is really similar. You know, you're trying to address avoidance and maladaptive and extreme beliefs that come about as a result of trauma. And I kind of think about it as two routes to the same end in a way, where you need to have both behavior change and cognitive change in order to see PTSD symptoms kind of come apart over time and decrease. And whether you go after the cognitive change first and behavior change through that, or the behavior change first, both have to happen. So I sometimes do CPT, but I prefer PE. It's just more stylistically in line with what I like to do. But I certainly use CPT either when PE isn't effective, or it seems like that would be a better approach for the client. So as far as similarities and differences, they're really similar in terms of the rationale. Both include an exposure component and efforts at cognitive restructuring. And differences, really, it's a matter of emphasis. In CPT, it is truly a cognitive therapy. So there's a lot of thought logs and reframing cognitions. And in PE, we really don't do explicit cognitive restructuring, even though cognitions change. We more allow the person, by highlighting different elements of the imaginal exposure and letting them really experience it over time, allowing cognitions to kind of change naturally.
Thank you, Dr. Moore. I've put information on the screen, so if you have any interest in getting more information or consultation with Dr. Moore, there's the number where you can reach her directly and be put in touch with the people who can help you make that possible. As far as recordings, they'll be available on Valant's website, and they will be emailed out. Recording of the webinar will be emailed out to everyone in attendance, and we will work on getting the rest of the questions answered if you weren't able to get to yours today. Thanks so much.
Thank you.